Hello, everyone. So we are really happy to welcome you today to our third live webinar in Aptisen. So today we will have a 1 hour presentation performed by Dr. PFÖRRRINGER from Germany. So the theme of the presentation will be arthrosis treatment and viscosupplementation with a focus on synovial VA. So as I told you, Dr. Dominique PFÖRRRINGER will present osteoarthritis and viscosupplementation, where we stand at today, and he will give us also some information on the guidelines and the review. And then he will do a focus on synovial VA, and we'll have also a third part on practical point of view from an orthopedist in Europe. Now I will give the floor. Yes, before I forget, all the participants can ask questions. If you have any question related to the presentation, you can write your question in the question section. And then at the end of the presentation, we will ask all those questions to Professor PFÖRRRINGER. Thank you. And so now I leave the floor.
All right, Bernina, merci beaucoup for this introduction. And I hope everybody can hear and see me really well right now. So thank you very much, everybody, for taking the time. 52 people on a Friday afternoon. I estimate that very highly that everybody is here. So thank you very much for joining us, for being with us, and for listening to this webinar today. Bernina, thank you very much for the perfect pronunciation of a not very easy to handle name in the German or Bavarian language, as we say. I practice back where I'm still on my slide where it says, does everybody hear me?
Yes, we can hear you perfectly.
Okay. Merci, because I just had some statics. Sorry. If somebody doesn't hear, please let me know if there's problems with the connection. It should work well, however. So if you look at this slide, it says basically my credo is conservative before operative. Of course, I'm an orthopedic surgeon, so our passion is always to do surgery, to help people by performing surgery. I very much believe that surgical approach can be very helpful. And I also think that joint replacement is a very valid approach if osteoarthritis is in its final stadium. But I still think that before we approach a surgical approach, we basically can help a lot of people with treating them conservatively before that. And I hope that we, through working what we see today, we can all have a certain agreement or see what the experience has shown us and what research has shown us in the past, and what also my experience has shown me in viscosupplementation in treating osteoarthritis patients. I hope, because I was just hearing that you could not see my slide, I hope it is now working. Yeah, so I'll switch to the next slide right now. And you can see basically that we saw not only is it possible for us to treat knee arthrosis, but even any other joint that can be properly reached through an injection therapy can be treated with a viscosupplementation therapy. Of course, dependent on how well you can reach that joint and how well this joint is prepared for a potential injection. I'm sorry, I still have statics from somebody in the background. If anybody that is not talking right now could go on mute, this will optimize the sound quality, I believe, for everybody a lot. And it says you can only see 95% of my slide or 98. That doesn't mean that everybody can see it yet. Does it work? I just need some feedback from you, please.
No, everything is perfect. It's just that we are all the audience is not there yet, but it's not related to your presentation. Don't worry about this. We have the full size, I mean, we have the full screen on your presentation. Everything is perfect. It's good.
Okay, shall we wait for further participants, or shall we just continue as we are right now?
No, you can just continue, and the participant will join during the presentation, and if they have any questions, they can just raise their hand, and we will answer based on the first part of the presentation. Don't worry about that.
Okay, so thank you very much. Excuse us for the housekeeping. I just wanted to know if everything is working fine, because technology is something that we're just diving into. And as we all learned in the last couple of months, a lot of things do not need to work anymore by meeting physically, but sort of we can do it technically. We just need to figure that everybody is happy and that everybody can hear us and can see what we're presenting. So you see basically in 2009 already, the review showed that the viscose supplementation can help a lot and can make life and quality of living much more bearable for those suffering from osteoarthritis. Of course, the larger joints are more prone to an injection therapy than the smaller ones are. But even if we look at it at Ritz arthrosis, so basically in the basic joint of the thumb, I've seen great experiences. I've seen great results with an injection therapy on behalf of my patients. In the detail, we have to look at it that I very much am in favor of giving a local therapy into the joint rather than giving a general therapy through an oral medication that is being taken by the patient. Why is that so? It is basically that we're treating the disease where it actually appears, where the pain comes from, and not treating it in general. Because if you take non-steroidal anti-inflammatory drugs, of course you kill every pain in the entire body, but not specifically only from the joint where it comes from. So in a lot of those cases, an injection of viscose supplementation can be a confirmation of the diagnosis. So through that, we actually learn if we're treating the right part of the joint. As we orthopedic surgeons know, in a lot of cases, knee and hip pain can be confused with each other because both joints are adjacent to each other and they are often affected in the same joint movement. So the thing is, what we also are looking forward to is a non-steroidal anti-inflammatory drug is only as effective as through the time that you basically are taking it. When you're not taking it, your basic pain killing is over. So that is not an advantage. While we have seen in viscose supplementation an antalgic effect of up to 6 or sometimes even 12 months. So we see a much more beneficial approach for the patient. And that is something that I see as an experience. Just last week on Friday, somebody came to me. He said he had been running. He's 72 years old. He had been on a run for 1.5 hours. He had been in severe pain. He received an injection from me, and on that same day in the evening wrote a message already that he was much better. And on Saturday he sent me a picture of him being on a mountain climbing there. So you can see you can have very effective results, and he still is very happy this week. So that is something where I think the patient satisfaction shows where we are coming from and what the decisive point is. So continuing in the presentation right now, we basically see that in further American studies, we could already see that even in the guidelines for the treatment of osteoarthritis in North America, there were relatively quickly no more concerns, but it was very easily proven, and the results were very clear, showing that viscose supplementation basically is a strong confirming factor. Of course, not non-controversial, because there were differing interests on that. Yeah, and I still see a lot of controversy in that, but I think the best proof, and I will aim at that later still, is the voice of the patient. And if you listen to the patient, what they tell you, that feedback eliminates controversy very, very quickly. So if we keep going, Of course, the coverage and the payment is one of the decisive factors, and that's different in every country. If I look at our participant list today, I've seen that we have a lot of participants from Latin America, a lot of participants from Europe, as well as other countries. Of course, in every country it differs. But what I can tell you is, in general, patients suffering from osteoarthritis have so much raise in quality of living that they experience that it is unbearable for them to continue as they do. And once they've received an injection with a viscosupplementation, they are relatively happy and glad, and thus, in most cases, very willing to step in if they can economically for it themselves, indifferent of payer situation because of the healing effect. I know that the non-coverage, especially in France, was a big topic, but gladly there was a success in the long run from the participants of a I wouldn't call it a riot, but there was a petition, and the petition unfortunately did not show success in that one, but in the end you can still see that there is difficulties, but on the end you see that the patients are very, very happy that viscosupplementation is existent and that it is actually being performed still, because it helps them in their everyday life. So if we keep going on that, we see that in 2015 it kept going, and that we then had a very, very differential approach, and that we looked a little bit more into detail of everything that we can see. And in the end, what we need to understand is that viscosupplementation is a very broad field. It is, as every medication in medicine, not one class that can be used as a group and that can be defended or that can be accused. But we need to differentiate very, very specifically between the products that are in the market. And of course, because it is a large market, osteoarthritis is a large topic for a lot of people. We have the problem, of course, that a lot of those interests are being mixed and mingled. And of course, the AAOS recommendation is one of the guiding factors for our worldwide actions that we as orthopedic surgeons follow, or that at least we look at. If we look into that, then we can actually see that we had in the controversy a lot of discussions, because then the American Academy of Orthopedic Surgeons asked themselves, is it the right treatment factor or is it not? Yeah, and that is still the big problem. But at the same time, we can see that the fact and the amount of reviews that have been performed, of scientific publications that have been performed, already raised the severeness of this situation. Just as we've seen in the last current crisis that is right now still hopefully soon to be fading out over this planet, the more interest there is in something, the more publications and the more controversial publications. But in the end, as I said before, I think the patient results are something that can be as convincing as any scientific study, or even more convincing. And I think that is something that is very, very important to understand. So if we look at it, in the end, I think from this publication, you can see even in the overall literature review, we now have a rather positive outlook on the entire situation. The doubts can be reduced and the confirmations can be raised. So gladly, we see something for the patient and in the interest of the patient that is now basically going in favor of an injection therapy. So that is something where we can see a positive development overall. In the end, we can see that the medical necessity is one point, and at the same time, we see that viscosupplementation has to undergo a certain standard of treatment. Of course, medicine does not always follow rules, and often in situations it follows the experience of a doctor and the positive attitude between the patient and the doctor. But if you can see, These are the criteria that you can see on the slide right now, and these can be the criteria or have to be the criteria for reimbursement. At the same time, if you look at these 5 criteria, the thing is, in other situations, if we orthopedic surgeons see that a patient can benefit from the therapy that we can offer to them, from my point of view, in a lot of cases, the experience and the positive results of the past have shown that an early set-on of a viscosupplementation therapy can prove beneficial early on to the patient. Of course, we all know the discussion of off-label use and conforming to, or basically sticking to certain rules of indication. As you can see here, this has a lot of radiologic criteria, a lot of objective criteria that can be objectively measured, and at the same time it has subjective criteria such as pain, because pain, even if we look at the visual analogous scale, we cannot really measure pain between 2 patients because every one of us experiences pain in a different level. And if you look at point number 4, the cause of the pain cannot be attributed to other forms of joint disease. It is very difficult unless you do detailed imaging and a detailed analysis of the sports behavior and the everyday behavior of the patient to really rule that out. So in the end, we're hoping for coverage, and of course we need to stick to those rules, but the experience of the orthopedic surgeon is the decisive factor for using viscosupplementation. So if we jump one ahead beyond this, you have seen that, of course, there is an indication for using all of this. The thing is, if you look at this with normal weight or moderate overweight, of course, we sometimes have situations where patients are severely overweight and they are suffering from osteoarthritis, of course, because on their joints there's more pressure and more stress. And at the same time, it says to consider patients' individual characteristics and patients' wishes. Of course, I need to demand to understand the biologic age of a patient. Somebody can be 75 and feeling and behaving like a 55-year-old, whereas other 55-year-olds are beyond the age of 75 in their biological response. So in the end, of course, it is a recommendation, but it is something that is in the end in the decisive hand of the doctor with the patient. You will see on one of the latter slides that I will present. In the end, it is the patient who gets to decide what he or she needs in terms of treatment. I think the same holds true for final decision on joint replacement surgery. The patient is the one who needs to be informed as positively and as completely by his doctor to have all the criteria that he or she needs to make that decision himself. But the doctor is only there to make recommendations. And the end, if you see, there is always people that believe in firm guidelines where you say this is very strict. But as we've just seen in the current virus situations, if you sometimes try things and follow the experience of very, very well-known and high experienced doctors, you can always gain a benefit for the patient in specific cases. And this is why we see in all these literature reviews and in an extensive overview of the literature that there is a beneficial result to it all. So if we continue in the slides, I can see that we need to learn basically from this U-shaped development. In the beginning, there was a high, I would say, positive approach and positive surprise on behalf of the doctors. But as it says, it is like a roller coaster, but a roller coaster is only a roller coaster if you've once been very high up and once been very far down. Otherwise, it's not a roller coaster. But we see basically that the experience and that the results of our patients show us where we need to go through. We need to go and look at randomized comparative clinical trials, and with that we understand basically where we're going to. At the same time, we see a high prevalence of osteoarthritis, and especially in the age group above 60, we see a high prevalence. At the same time, we see that through demographic changes in most industrialized countries, The demographics are changing away from where in the past it used to be a tree like this. It is now basically a tree that is shaped like this, or some call it a vase, where you have a belly in the middle. So we have a lot of people that are now entering that age, whereas less people in younger ages are coming and joining into that. This is something we could discuss on for a long time, but it's not about demographics here. It's about those people suffering from osteoarthritis in the end. So the thing is, if you look at it, we have a lot of those studies that have overviewed a large patient population where we have situations that have been difficult. At the same time, we are now looking at the long-term efficacy and the safety evaluation of an intra-articular injection of Synolys, based not only on sodium hyaluronate, but also combined with sorbitol. So the sorbitol, basically, for most of us known as sugar, is the decisive factor to change the chemical or biochemical properties, and through that the physiological properties inside the bone, or inside the joint, not inside the bone, inside the joint. That is something we need to decide upon. And we see that basically a lot of people, if you look at it, in the 201 patients could be included in all of this. So 197 patients were included in the study. You can see on the right-hand side of this slide, you can see all the correct characteristics that we had at that point. We see in what grade, in terms of Kellgren and Lawrence scale of osteoarthritis, people were, and how long their history with that disease has been already. At the same time, you see the visual analogous scale of pain at 62.5, so a level that is in a relatively high yet bearable, but at the same time deserving treatment. So if we look into this, then I can look into the further scores of all of this. And then we see that in the comparison with another preparation, the Synolys posed a significant advantage, and there was no downside in all of that, because we see a good reduction in the pain scale on all of that. Yeah, and of course, most important is that the new preparation is not inferior to anything else, but it shows an advantage overall, which poses a reason to use the new formulation. So if you look at this from the point of basically the two results that you can use is stiffness and joint function. So of course, especially what osteoarthritis patients describe as the morning stiffness, that is something where you have a high difficulty to alleviate that. And at the same time, the joint function improvement is very, very important. In both groups, we have a significant improvement and a significant raise in quality of living for both of them. Yeah, so you can see that the efficacy is basically 6 months post-injection really well and on a very, very good outcome. So if we look at this, then you can see on this side, basically the test groups, they were almost similar on both cases, as you can see here, and we can still see that the results are very, very convincing for both preparations in our overall score. So if we continue, whoa. I'm sorry, that is something that is wrong in here. So if we now go basically into the details of where we are going right now, it is about everyday use. And the interesting thing is basically that the situation using osteoarthritis treatment as an injection is something where the patient is in such a high level of pain and it has such big difficulties that he or she deserves an immediate treatment and is willing to trust the doctor a lot. I will go into the details of this in 1 second. So if we basically look at it, the first thing is that we need to do is a physical examination. The doctor needs to have the patient's knee or joint in his or her hand to look at it, to examine the joint and to see where the difficulties lie in that situation. While in this situation, as you can see, sitting on the foot, you can fix the leg, you can see, put stress on both meniscuses, put stress on the cruciate ligaments, and see where the patient has pain, where the patient has difficulties. And through that, we can already examine and go into a situation where we are related to the patient and we are in contact with his joint, and where we are in a situation where we say, okay, we can offer something mechanical to solve a mechanical problem right now. And what is basically the detail? If you look at it, this is from my experience in the everyday practice. The patients love to rely on the experience and knowledge of the doctor. So experience comes from years of treatment, as well as, of course, many reviews, many studies, many materials that you've read through. What I have basically shown you in the first half of our presentation is how the literature has gone through various controversies. Because of course, as we all know, we will be in the situation where a doctor is being questioned by the patient, well, what is for and what is against this treatment? What is the practical approach to all of this? So the situation is the patient wants to know, what does that mean in practice every day? And then it is, of course, for us the nicest situation if we can say we can offer a one-time injection that will solve your problems and that will make you get rid of it and that will let you return to the previous activity. And that is something where I've seen the best results, because as it says, the doctors are the primary source of information for the patient. The patient has no idea of where he or she is heading, but the doctor is of course seeing a lot of these patients and thus has a certain amount of experience that he or she can dig into and that he or she can share with the patient. So in the end, it is of course something where they ask, okay, what else can we do? If we don't do this, what else can we do? And if you look at a relatively progressing degree of osteoarthritis, then of course for them, one of the options that can be shown to them is an operation. But if you can get somebody away from the operation, which is something that is tedious, that takes time, that bears a certain risk, and that you can offer them an alternative to doing so, and they are very happy and thankful to be doing so. So it is about showing alternatives and showing a potential range of treatments. Of course, some people can be helped by physiotherapy. Some people can be helped by corrections in the shoe or in the inlay in the shoe. Yes, but in the progressing degree of osteoarthritis, most of these things have been already adopted, they've been tried, they've been more or less successful, but if they're not as successful as we wish, then we need to offer the patient a range of treatment and then show us their experience. In the end, as I've outlined and that I've mentioned a lot of time, the results are most convincing and by far more convincing than all research on this planet, because results show the doing of our work and they show us how successful we've been. And when treating hundreds of patients, we see only very few that are not happy with the injection. And in the end, we see way beyond 90% people who are very happy and who have a very positive outcome. The practical approach is in the end something that the injection is relatively easy. In the Synolist preparation, you can see that the hyaluronate as well as the sorbitol are pre-prepared in a very elegant format of an injection. So something where the doctor just basically can come with the needle first. He or she can provide a local anesthetic to the knee so the patient doesn't feel the injection quite as much. And after all of that, I think it is very important that the doctor shows that he or she is very experienced in doing that. I think for a physician, it is not as easy always to select the right choice because we've been offered so much basically around that field that we need to show there is a high diversity. And yes, we've thought about a lot of things, but in the end, all painkillers are only basically covering the red warning light of pain. Any Treatment like physiotherapy or changing of behavior can only prolong the situation, but cannot treat the symptoms of osteoarthritis. Of course, we're trying to tell those people that are slightly overweight to lose some body weight, to reduce their body mass index, to ameliorate their situation. But in the end, they want to have a solution. They want to have it fixed. And if you look at it basically from a carpenter's point of view, you can see an injection of hyaluronate basically as the WD-40 of medicine. You're solving a problem relatively quickly through an easy topical approach into the joint where the movement is happening. That is where we give the body what it is used to, something that is a natural product and something that is being dispersed through the joint and that helps the patient immediately. The fascinating situation is that patients are relatively easy convinced if I inject them Synalise, for example, because they hear it in the first moment. You can hear it in the knee joint once you've injected it. It is very comfortable to be injected. And in the choice, once you've used it a couple of times, you're so comfortable with it because you know that the patient is going to feel much better, that the choice is being made much easier due to the result. As I say here, the result is more convincing than any research on this planet. And so through that, the choice is made much easier for both the physician as well as the patient. I sometimes have patients who are being recommended by other patients that tell them about their injection with the Synalise preparation that they had experienced with me. And they say, I want exactly that because I'm in the same pain, I have the same difficulty. So that makes the selection for me as an orthopedic surgeon much more easy, and through that I can decide and understand what the patient wants and offer this to them. So if we look into this, the combination of the hyaluronic acid and the sorbitol, that is basically something where we've seen the best results. Why is that? Because both viscosity and elasticity, the decisive factors of the treatment, they are elevated in comparison with the other preparations that we know, and especially under the pressure. In the knee joint, in the hip joint, we have high pressures. Research has shown that up to 3 times the body weight of the patient is on the knee while he or she is running. So we see that there is a high pressure situation. And in this case, the preparation between sorbitol and the hyaluronate shows the perfect result for the patient. That is something that he or she feels every day and that he or she experiences every day. This results, of course, in bullet point number 2, as you can see here. Patient satisfaction is extraordinarily high. And if I write extraordinarily, it means that some of them thank you so much because they are so happy. As I described that patient from last Friday, who was then all of a sudden on a mountain. It was a situation that he could not have imagined anymore, climbing a mountain, stepping onto the mountain, that he sent me a picture from there and said, look, I'm climbing the mountain again because you basically made my joint pain-free. And what I basically from that get is the most beautiful aspect of medicine. Why is medicine so fulfilling, and why can it be that we all love our job every day, that we don't consider it a job, but more of a passion? Because we make people happy. And it's something where I, through an injection as the one I described, I can make a person happier, I can raise their quality of life. And through that, the patient feeds it back to me and says, thank you very much. I'm extremely thankful for what you've done to me. And I'm very happy right now because I can go back to my everyday activity. And that leads to a situation where the doctor is in the end also happier. So that is something where I can say this is what is most convincing about using the combination of sorbitol and hyaluronate. So what we see is in Synalise a perfect result, and I can put it basically into one very easy and basic equation that Synalise makes the people happy. It makes the patient happy, and through that it makes the doctor happy. So I'm super convinced that this is a great preparation. I can only tell you that you should try it, that you should step into that situation, give it a try, find a patient that looks as if he or she could benefit from that situation, as mentioned before in the criteria where you might have tried other forms of therapy. But once you're there, it would be very helpful to basically also feed it back to us, feed it back to the team, to Bernina, to myself, so that we can learn and experience more of what you're seeing. And with that, I'm basically at the end of what I can show you. I'm convinced through the preparation. I was very critical in the beginning. I had a lot of doubts that there was a new preparation because we doctors tend to stick to the old situations, but the results convinced me a lot, and the happy patients have convinced me as well. So I think we're now in a situation where we can go into a wonderful discussion, where we can have basically a Q&A session where I'm happy to take your questions. You can put them into the chat and I will answer them. I will repeat the question verbally so that we can all jump into that, and you can raise the questions to me. Of course, we will also be available afterwards. We will be available for questions. If you want to address questions to me, you can find me online. You can find my email address. Feel free to contact me. I'm very happy to answer the questions, to tell you about me, my experience. If you need a therapy, I'm very happy to basically consult you, to help you, to refer you to the ideal doctor in your geography. And I'm very happy to look into that situation. And I would be happy to hear from you what your experiences are, and I hope to share with you the satisfaction and the happiness that people have gotten out of being treated with the Synolys. So with that, I thank you for your time. I look forward to future setups, be in personal exchange with you, where we can have a more lively Q&A session. But right now we will do it digitally, and I'm very happy to take your questions.
Thank you very much. So we have our first question. So I will read the question for you, if it's okay.
Yes.
So the question is, can we associate Synolys with depomedrol?
Can we associate with Synolys with depomedrol? With that, I need a little bit of support, because depomedrol, I need to have basically a potential translation into what it would be in our geography. But I'm happy to take that question. Just give me a minute.
Yes, maybe we can ask to the person who...
Yes, okay, I'm into it. Yeah, depomedrol is something where it's a steroid, and there is no contraindication from our point of view to use that in combination. I would not, of course, take it into one syringe, but of course, let it the chance to in the joint both be effective. At the same time, I tell you from my experience that with other hyaluronic acids, you might need the steroid. But at the same time, I've experienced that Synolys is so effective that you don't need it anymore. So you're basically sparing the patient from the prednisolone, because you only need to give him one medication. That is my experience. But of course, there is the chance to combine the two.
Thank you. And the other question is, what is your experience in Synolys in trochanteric bursitis? Sorry.
Yes. So bursitis trochanterica, as we call it, you see the Germans still love the Latin approach. That is something where we've seen positive results because it basically can help the bursa to slide over the trochanter. That can be a very helpful situation, as well as we sometimes see it in the iliosacral joint. The iliosacral joint, once you're in there, you're firmly in the joint. If you inject the people with Synolys, you will see magnificent results, because also in there, in that joint gap, you can see very good results. So for both indications, you can see that, yes.
Okay. We have also another question.
So I can see another question. Have you ever used this approach for wrist arthrosis? Yes, I have. Of course, the arthrosis in the thumb joint is something that is a little more rare, but we see it more and more now, because people tend to use their cell phone, and through that they have the so-called cell phone thumb, and through that is a basically rising pathology. That is something that we see. Yes, you can use it. I advocate people to use more of a local anesthetic before, because people are not as happy to receive an injection into their thumb as they are into their knee, for example, or into their hip. But yes, it works really well. what you need to take into consideration is that sometimes you don't need the entire amount that is in one syringe because the joint is really small and it doesn't need as much as there is in one injection in all cases. But it still can work, but sometimes you don't need the 4 ml basically, but you can use less of that. Or if the patient has difficulties in both thumb joints, you can spare it between the 2 hands.
Okay, thank you. Is there any further question from the participants? Maybe on the practical aspects that was presented, or maybe the relation between the physician and the patient. Okay, is it possible to repeat your answer, doctor, regarding Synolys and steroids? Someone missed maybe the beginning of your answer.
Yes, I'm happy to answer that. So I was asked if a combination of prednisolone with Synolys is in general possible. As I said, I have positive experience in doing so. I would not recommend basically mixing them in one syringe, which technically is A, difficult, and B, doesn't make sense. So there is a technical possibility to do so. But from my experience, I've seen that Synolys works so well and through the sorbitol sticks so well to the situation in the joint where the osteoarthritis is causing the pain that we don't need it. Because why is prednisolone being given? To reduce the inflammatory aspect of osteoarthritis and to thus reduce the pain. And I have experienced that with Synolys, this sometimes is not even needed. So I recommend to you try Synolys alone. If you still need prednisolone, you may combine it.
Thank you. We would like also to know what is your experience regarding traumatic OA, you know, with the more specifically with sports and athletes.
Yes. So regarding traumatic and sports related osteoarthritis, I have very positive experiences with that because in a lot of situations, an athlete has a lot of basically liquid in his joint which doesn't belong there after the injury. So if that is something that can be solved and that can be removed, you're in the joint already with an injection needle, and through that you can then use Synolys, and through that you have two aspects. Basically, you're giving back the athlete the lubricant for his joint, protecting his cartilage, protecting his joint, and basically delaying a potential onset of post-traumatic osteoarthritis. So it can be very good in the acute situation, but it can also be good in delaying basically the development and the progression of osteoarthritis related to a trauma. So I've seen very positive experiences with that. It, of course, is always a question of the indication, and there is contraindications like acute fractures or open wounds or infected wounds where I would not recommend using it. But in all other situations, as described before, I've seen positive results with Synolys.
Okay, thank you. I have also a question for you, because you know I know that the experience and the result that the physician have based on their practice for their patient is most essential, but we still need to have clinical study to prove the efficiency and the safety of the product. So that's the result that you showed earlier. But I think it's difficult to explain to physicians that the difference between the crosslink and the linear HA in terms of performance. What is your opinion about that?
So basically, the differentiation between the various offerings of hyaluronate is being asked. Well, I think it is, of course, the clinical results which we've seen earlier in pain reduction and duration of pain reduction, which is one decisive factor. At the same time, the other decisive factor is what the patients tell you. So basically what the experience that is being reported back to you. And I've seen through the sorbitol that the sinulus seems to stick in the joint for a longer amount of time, and that it seems to spread out and be more coherent than other preparations do. So I see a big advantage in that, and this is basically my experience, and through this, my scientific approach, that patients are happier for a longer amount of time in comparison to other preparations.
Okay, thank you. There is another question on how many times can we infiltrate a knee if patient has good result after the first injection? For example, how many times a year can you inject?
Well, that is an interesting question. Of course, technically one could inject very often, but I would warn people from that. I would say it is basically how often does the patient need it. I would say it is always a question of the need of the patient. My experience is that in sinulus we have such excellent results that the patients need it basically twice a year. So every 6 months they come. Of course, sometimes they say, okay, I'm now going on a round the world trip, or I'm going on a cycling tour across the Alps. So they are basically being supported for that prior to some, I would say, above average use of their joint. Then they can come more often. I would recommend not doing it more often than every 3 months, because of course every intra-articular injection poses a certain risk. And the more often we do it, the more the body at one point might say, well, I don't want this anymore. Yeah, just to translate this into a very easy language. So the clear answer is, how often does the patient need it? From my experience, twice a year is a very good treatment ratio. And in addition, sometimes it helps if people sort of suffer from a knee arthrosis, if you also look into their hip, if the hip might also be affected, because that's quite often the case. Then of course you combine it in the various joints of the human body on a more frequent basis. But in the end, as I say, the patient is the decisive factor on the frequency.
Okay, thank you very much for this complete answer. Do we have any other questions from the participants? Let's check. No, I think that we have. Yes. When do you perform an injection in the thumb arthrosis? Are you using imaging guide for the injection?
I just need to understand in which joint. That was the first part of the
thumb,
question.
The hand, for the hand. The
head.
Yeah.
Yeah. Image guiding can be very helpful in certain situations where I cannot get the joint gap. If I cannot feel it, if I cannot judge it with my 2 hands where it is, then image guiding can be helpful. This can both be done with ultrasound, because on the hand, ultrasound reaches deep enough to show me the bones, and ultrasound is more sort of sparing for the patient, and I can do it in my hand, in one hand, even in a sterile environment while the injection. On the other hand, yes, X-ray can be helpful, but it's not needed in a lot of situations. I'm using a handheld ultrasound device that I can use, and in combination with a sterile gel, you can use it. You can look at the joint and then do the injection while you're holding the ultrasound on it, and through that you can even see the needle. So that for me is the ideal combination.
There is a question written in the question section, but we don't really quite understand the question. So we will unmute Dr. Valles, if it's okay.
Yes, please.
Like this, he will ask you the question directly. Let's see, Dr. Valles. Yes, here you are. We found. Give me 1 second.
Okay, do you hear me?
Yes, we can hear you now.
Okay, so my question is about the hyperuricemic acid in the joints. So if it's safe to infiltrate synovial in a joint that have crystals for hyperuricemic acid or gout.
Would you help me understand the question? I didn't hear the last part of it. I'm sorry.
If it's safe to inject synovial in a joint that have hyperuricemic acid or gout.
Yes, now I understand. Now gout, yes, as we say Gicht in Germany, yes. So is there something that is a contraindication? Of course. I would have to say, I mean, gout mostly appears in the joint of the largest toe, and that is rarely affected at the same time by arthrosis, because the situation is that the arthrosis, the osteoarthritis, can then be caused by crystals. But then, of course, I would try to solve one after the other. So into a joint that has a crystal in it or a potential pain situation that comes or is a result from a gout, I would first try to lower the uremic acid in the body through a medication. And once I've done so and the patient is still suffering from osteoarthritis pain, I can then treat this pain, and of course I can then use synovial. That works really well, yes. But one after the other.
We have also a technical question more about what is the best approach to inject synovial in your opinion? Is it the lateral suprapatellar, the medial suprapatellar, or the medial parapatellar tendon?
That's a very good question, because that's something that I'm in continuous exchange, and sometimes I see patients that say, well, I have so much pain in the medial side. In the end, as we all know, the joint inside has plicae, so folds. Yes, but in the end, it is still one communicating range. I prefer the lateral suprapatellar approach because it's easier to reach and it is a natural soft spot. So through that, you can really get into the joint really well. I know in a lateralized patella, sometimes the medial approach seems easier to get, but then in the end, for me, it's often cases it is not, because the joint starts in a different level on the medial side than it does on the lateral side. So in the end, the lateral has, for me, shown more advantages and more easy to catch. And what I then do, if the patient is of course lying in front of me, once I'm done with the injection, I put a band-aid across the injection spot, and then I move the joint with the patient for about 90 seconds. So I have the chance to spread the synovial in the knee and with the patient. The patient appreciates that, and I get an immediate feedback because I hear how the injected substance is spreading through the joint. So suprapatellar lateral approach is my preferred access. Not the only, but preferred.
We have, I think that we have our last question now. The treatment with synovial for patients with OA, knee OA, is it more 6 months or a year based on your experience? I mean, how long do you see your patients to come back to you to be to relieve the pain again after an injection with synovial?
Very good question, but again, dependent on the patient. There's patients that forever are happy after one injection and they come back after a year or even after 2 and say, I'm still happy. In most cases, my experience shows between 6 and 8 months, the patients would come back and say, well, right now it's slowly coming back. At the same time, it's a matter of season. We live in a season or in an area where the cold is then coming back. So if I was treating a patient basically in March for the last time, they would be happy through most of the summer, but then would come back in October because it's getting colder again. And that has effects on that, even though there is no logical approach that I would understand, but it is comfortable for the patients. So in most cases, people come back somewhere between 6 months and 6 months plus, I would say. But it depends. It depends on the body weight. It depends on the level of activity. It depends on the activity level and the psychological status of the patient. So a lot of factors that co-found this answer.
Perfect. Thank you very much. I would like to thank you. Dr. PFÖRRINGER, for this excellent and really useful, presentation. Because for us, having the perspective from orthopedists is really important. I mean, all our work is to make sure that the patient and the physicians have the best to treat the OA patients. So thank you very much for sharing your experience. Thank you for the participants for all the questions that were raised. We are so sorry for our physician from the Latin America if the session wasn't in Spanish. So we will see how we can find a way to maybe translate the answers that were asked in Spanish for you to have all the answers from Professor PFÖRRINGER. And I think that we are done for this third live webinar. Thank you very much once again. And
Ermina, just one correction, not professor yet, but on the way to become.
Yes, sorry,
so,
doctor.
Yes, just on the way, so doctor. And of course, if you can send the Spanish questions on, I will find a translation platform and I will try to get back to all of you having asked a question. If you just add with your question your email, I'm happy to write back via email to each and everyone asking a question in a language that I don't speak. I only speak German, Italian, a little bit of French and English. With all other languages, the internet will help us, and I'm very positive that we can get a sufficient answer back to you.
Yes,
so just keep sending them on with your email address, and I'm happy to answer each and every question to you.
Thank you so much.
My pleasure.
Bye, everyone. Bye-bye.
Goodbye.